I think the major issue, of course, is in patients who are in complete remission, CR1, and there I think it's a dynamic assessment, firstly of predicted risk of relapse if treated with chemotherapy alone, and that can be defined, of course, but the quality of the remission, the MRD testing is probably important in that setting, as Professor Grimwade has shown. Also cytogenetics and molecular analysis. And then broadly, if you have a good donor available and patients are fit, that the rule of thumb, certainly for sibling and well-matched unrelated donor transplants, if the predicted risk of relapse is much north of 40%, then patients will benefit from an allograft. Critical, of course, to that is what we discussed just a minute ago, which is careful comorbidity scoring. And the data we have generated with the BSBMT is that if your comorbidity score is 2 or much higher, then your predicted transplant-related mortality really rockets up. It's a rather blunt tool at the moment because we're not sure how to weight each of the individual comorbidities, but it's certainly transformed how in Birmingham we're assessing older patients to take to allograft. We're very comfortable, if they've got a good donor and a significant risk of relapse, of taking patients above 60, sometimes up to 70, a little bit older if they're really fit, to transplant. Good confidence that the outcomes will be encouraging, but it's in patients who've got multiple comorbidities, and we might have been transplanting these folk 5 or 8 years ago, that we're really very concerned whether that's the best option.